On the CT and MRI images we can see the metastasis. Preoperatively we want to perform portal vein embolization in segments 5 to 8 in order to induce a hypertrophy of the future remaining liver prior to resection. On the video of the CT scan here in the venous phase we can see there are multiple metastases in both right and left liver. The surgeon is planning to perform resection of the segments 5, 6, 7 and 8 with an atypical resection of metastases in segments 2 and 4. On this MRI we can see that a cycle of chemotherapy has been performed successfully in the patient as size of metastasis has reduced and some of them are even not visible anymore. Before performing the embolization I always studied a CT scan looking at coronal view to find the best way for me to get into a portal vein branch. The yellow line here is showing the optimal access into a portal vein branch. To perform liver puncture I am using a very thin and long van Sonnenberg needle using a 45-degree angulation approach. I normally enter below the rib number 9 or number 10 in anterior to mid-axillary line with the needle pointing toward central part of the liver. I remove the mandrel of the needle and connect the hollow needle with a syringe partly filled with contrast media. I slowly retract the needle until aspiring dark blood. Then I inject a very small amount of contrast media to confirm the right needle position in a branch of the portal vein and not in a liver vein. It can require several attempts to gain access. Then you introduce a 018 guide wire deep into the portal vein system, optimal in the direction of the superior mesenteric vein. You exchange the needle for a 4 French introducer or a 4 French catheter and exchange the 018 wire for a 035 wire. Move to a 5 French short introducer and perform your portogram through a 5 French sidewinder catheter lying in the confluence of the superior mesenteric vein and the splenic vein. It is very important to do a good intervention planning using the CT scan to define which branch you are going to embolize, especially when it deals with segment 4, as the portal vein comes sometimes from the left side and sometimes from the right side. Now I introduce my direction microcatheter together with a 014 guide wire. In this case I take the large lumen high flow version. First because it enables me to inject a high amount of contrast media with high pressure to get very good quality imaging. Then because I will inject my Glubran mixed with lipiodol. Here you can see on the super selective portogram through the direction that is in the right position to start embolization of this portal vein branch. Usually I use a mixture of lipiodol and Glubran using either a 1:1 or 2:1 ratio depending on how liquid it needs to be and how far you need to go into the liver. Glubran being very aggressive with both syringe and catheter, you have to inject quickly into your catheter. Very important, you need to have many syringes filled with 20% glucose in order to flush the catheter between each injection. You should not use normal saline to flush your catheter because then the catheter will be completely stuck. When I start embolizing the first branch, I usually inject a very small amount of Glubran and lipiodol, around 0.1 milliliters, to test the mixture and feel how it is going to react in the portal vein, how far it goes. Then I flush with a lot of glucose. It can differ from patient to another. Here you can see that first part of embolization is successful as the branch is completely occluded. Here you can see I reposition my direction microcatheter. In this case I was able to do it without a need to reinsert the wire. That's very helpful, as in those cases where I use Glubran and lipiodol, normally your catheter is a little bit filled with these substances and it can be very hard to reload your wire. Direction microcatheter is enabling you to reposition without a guide wire. The portogram shows my catheter is in the right position to perform embolization of the second portal vein branch. Portography is showing excellent result and complete occlusion of the second branch. I reposition direction microcatheter again, moving very easily to the next portal vein branch. Here again I am really satisfied with its position and I can embolize the third branch. Here is the portography after third branch occlusion. I move to the fourth branch without a need for reloading the wire. At that stage, another big advantage of direction. It is still working after the first 3 injections of Glubran. It is not stuck and I can complete the embolization. In this final photography we can see successful embolization of the 4 branches as well as the central part and the left system of the portal vein still open. At that point I normally retract both the catheter and the microcatheter as well as the introducer, and I inject a small amount of Glubran in the branch I used for the access in order to avoid the bleeding. Embolization is successfully completed. I could reposition direction in 4 branches using a mixture of Glubran and Lipiodol, flushing extensively with 20% glucose, and I was able to perform the whole procedure with the same microcatheter. Here is the CT scan 6 weeks post-embolization and partial resection of segment 2. We can see the Glubran and Lipiodol. The result is very good as well. The desired branches are occluded and there is a hypertrophy in segment 1 especially, as well as segment 2 and 3 when comparing to the pre-interventional imaging. Here is an imaging 2 days after resection of segments 5, 6, 7 and 8 and partial resection of segment 4. There is some fluid around the liver and the patient also has a large pleural effusion on the right side, but what you can also see is that segments 1, 2, 3 show a very good hypertrophy after portal vein embolization. Being able to reposition direction microcatheter in case of several branches embolization enables to save time. In those cases involving glue, where it's not always possible to put in a wire again, this is really a big advantage. Direction microcatheter has also an outstanding pressure resistance which ensures high quality power injector series. There are different tip configurations, different sizes. The system is available with different guidewires. In other words, whatever the target, you can have the right configuration to reach it. Finally, direction is compatible with all kinds of embolization materials, so you have no limits for your procedure.